Lily Ladner. She graduated from Bernard College with a degree in neuroscience. She is currently a medical student at Virginia Tech, and she's going to talk to us about her research on TBI.
Yeah, cool. Thanks for having me, guys, and thanks for a great first couple of weeks with the team. I'm excited for the next few. So my presentation is titled Translational Investigation of Vascular Permeability Factors in Traumatic Brain Injury. And it's a collaboration between the Center for Neurotrauma at Virginia Tech and the Department of Neurosurgery at Carilion Clinic. So we all know that traumatic brain injury is a highly debilitating and prevalent condition. It affects between 47 and 69 million people worldwide each year. When you zoom into the state of Texas, Texas is actually the second most common place to have a brain injury, with 144,000 people affected yearly. It can cause a variety of deficits, including deficits in attention, memory, and executive functioning. And despite these known deficits, there are few good prognostic biomarkers, nor are there good treatments that target TBI-specific pathophysiology. So what is TBI pathophysiology? When a patient experiences a brain injury, they experience two forms of injury. The first is the primary injury, which is the direct response to a mechanical insult to the brain. The second is the secondary injury, which is a more chronic, insidious dysregulation of neuroimmune and biochemical pathways. There have been many attempts to subcategorize the secondary injury and use it as a therapeutic target, and one such attempt subcategorizes the secondary injury into endophenotypes, or a set of distinct characteristics that can be quantified and subclassify a group. Diffuse axonal injury is one of them, cerebrovascular injury is another, and neuroinflammation is another. In my lab, we focus on cerebrovascular injury, and in specific, we focus on the blood-brain barrier. Now, this is a very oversimplified graphic of the blood-brain barrier, but as we all know, the blood-brain barrier is composed of pericytes, basement membrane, and endothelial cells separated by tight junctions. Here we focus on tight junctions in those endothelial cells. In my lab, we study a pathway called the angiopoietin-Tie2 pathway, which modulates vascular endothelial stability through regulation of those tight junction proteins. Angiopoietin-1 is a protein that causes increased vascular stability by increasing tight junction protein expression, and subsequently causes increased blood-brain barrier stability. Angiopoietin-2 does the opposite. It causes decreased vascular stability through decreased tight junction protein expression, ultimately causing a leaky blood-brain barrier. What I find interesting is to study this pathway in diseases where the brain vasculature is highly dysregulated, like in traumatic brain injury. So the first question was, how does traumatic brain injury affect this pathway in a mouse model? Mice were administered a controlled cortical impact model of brain injury, or CCI for short. They were then sacrificed. Some of their cortical tissue was extracted. It was exposed to anti-CD31 microbeads to isolate endothelial cells and really focus on that pathway. And then the cells were processed using qPCR. What we found was that there's a significant level of blood-brain barrier dysregulation in the mouse model of traumatic brain injury, as evidenced on the right-hand side by decreased expression of angiopoietin-1 in the CCI model, and increased expression of angiopoietin-2. And again, angiopoietin-1 is that vessel stabilizing protein, while angiopoietin-2 is destabilizing. So this highlights some level of blood-brain barrier permeability in the mouse model. The next question was, we've shown that there is some level of dysregulation of this pathway in a mouse model of brain injury. Can we perhaps target and modulate this pathway to attenuate some of the neural damage caused by brain injury? So what we did was the same exact experiment. We did a controlled cortical impact model of brain injury and administered vasculotide. Vasculotide is a synthetic mimetic of angiopoietin-1, the vessel stabilizing protein. Mice were then sacrificed, their brains were sectioned and Nissl stained, and the volume of the lesion caused by the brain injury was then measured. What we found was that administration of this angiopoietin-1, or vessel stabilizing protein mimetic, resulted in a significant reduction in lesion volume in the mouse model. And we can see that on the right-hand side, suggesting that possibly this pathway may cause some level of cell death, and that we can attenuate the cell death by administration of vasculotide. This question was, we now know that there might be some level of dysregulation of this pathway in the mouse model. Can we replicate this in a human population and translate it into the clinic? So this was a prospective study at Carilion Clinic of patients with moderate to severe traumatic brain injury. Serum was drawn at 24, 48, and 72 hours following their injury, and ELISA tests were done to assess for protein levels of angiopoietin-1 and angiopoietin-2. So what we found was that the data tended to replicate the preclinical data in showing that there was some level of blood-brain barrier dysregulation through dysregulation of this angiopoietin pathway. What we see on the right-hand side is a significant reduction in angiopoietin-1 expression in the human population at 24, 48, and 72 hours, as compared to control samples in the red line, and a significant elevation in angiopoietin-2 protein. And this again suggests some level of vascular dysregulation in the traumatic brain injury population. The next question was, can we use this as a diagnostic biomarker? So can we compare this to variables that we already know to be associated with TBI severity? And to do so, we assessed the association between angiopoietin-1 expression and the Glasgow Coma Scale. And while the Glasgow Coma Scale is subjective and not without its flaws in determining TBI severity, there was no known association between these proteins and the Glasgow Coma Scale, suggesting that these aren't necessarily good diagnostic biomarkers. Next question was, can we assess the utility of these biomarkers in determining long-term prognosis? So can we develop a prognostic biomarker and thus a potential therapeutic target? And what we found here, we're looking at ROC curves of the angiopoietin-1 and angiopoietin-2 protein expression with specificity on the x-axis and sensitivity on the y-axis. We found that there were pretty high AUC values of these proteins in predicting 6-month Glasgow Outcome Scale, which is a scale that reflects functional recovery in association with traumatic brain injury. There was AUC values of 0.92, 0.92, and 1 for angiopoietin-1, angiopoietin-1 in combination with angiopoietin-2, and angiopoietin-1 in combination with GCS. And while there is no way I can claim to have developed a perfect model, and this is likely skewed by a small patient population, this does suggest that there might be some utility of the angiopoietin proteins in determining a long-term prognosis for TBI patients, and they may serve a value as a prognostic biomarker. So overall, the study first shows that angiopoietin expression is affected by a controlled cortical impact model of traumatic brain injury, and that the associated neural damage may be reversed by a mimetic of the angiopoietin-1 protein. Second, that this expression is affected similarly in the human population and may serve a more prognostic but not necessarily diagnostic role. And third, we haven't yet determined whether there is some long-term therapeutic value of angiopoietin modulation with this vascular-tied angiopoietin-1 mimetic. So that's something to do in the future. Limitations of the study include that we have a small patient population. It's not necessarily certain whether there's good diagnostic utility of the Glasgow Coma Scale in determining severity and the Glasgow Outcome Score in determining long-term outcome. We don't yet have a non-TBI injured control group, which is something that's important to consider because patients with polytrauma tend to have diffuse vascular injuries. And this is a novel therapeutic, so really bringing it to the market would take some time. Some future directions include increasing that sample size, possibly subclassifying TBI into different patient populations based off of location, type, and severity. And then some genetic studies, so looking at further investigating these proteins and their expression. And then possibly in the future, if we do get a large enough patient population, bringing this into a phase 1 trial and thinking about how we can implement it into clinical practice. So there were a lot of people who helped out with the creation of this study, both at Virginia Tech and at Carilion Clinic. And I really appreciate your time. I can take any questions.
What was the therapeutic?
It's called vasculitide. It's a synthetic mimetic of the angiopoietin-1 protein.
Is it FDA approved?
It's not.
It is not. Okay.
Yeah.
Who makes it?
So we collaborated with a chemistry group at Virginia Tech to synthesize it.
Okay, so you guys are making it.
Yeah.
Interesting.
You might have said, but so who is the major producers of angiopoietin? Is it like a paracrine signaling from damaged endothelial cells to other surrounding cells, or is there a systemic immune cell involved?
Yeah, so it varies. Angiopoietin-1 is expressed by endothelial cells. So what we see is that in injured vasculature, angiopoietin-1 is released. Angiopoietin-2 can be expressed on endothelial cells, but is also expressed on some circulating immune cells, so we see it more diffusely.